Just a minute.
Okay, Doc.
Okay. All right. Okay. Good afternoon, class. Sorry, I couldn't meet you for a face-to-face lecture today. So, trying to keep all of you safe until my COVID test results come back. So, yeah. Anyway, so we'll be discussing lower respiratory tract infections today. And if there's time, we'll also talk about pulmonary edema. We've been talking about it a lot in terms of heart failure and then its complication there as pulmonary edema. But if there's time, we'll try and then go a little bit into detail. And we see that pulmonary edema can also result from other things apart from heart failure. Okay, so we'll try and talk about that as well. With the lower respiratory tract infections, we'll talk about bronchitis, and then we'll talk about bronchiectasis. We'll also look at emphysema as well, okay, which is more of a distraction of the lower respiratory tract rather than like an infection. It's more of a distraction there, so more of an inflammatory process, okay. So let's start off with the lower respiratory tract infection, since that is a little bit closer to pneumonia and then TB. Once you have any question, you can just put your hands up, and then we take it from there as well. So we'll first look at bronchitis, and as the name suggests, our primary focus here is going to be on the bronchus. Okay, so you know with the lungs you have the left and then the right main bronchus, and then from the left and right main bronchus you've got some other branches over there. And once we are talking about bronchitis, remember when we're talking about asthma, the focus was also more on the bronchus, and that's why we have bronchial asthma. So you realize most of the things here are a little bit similar in terms of presentation and even in terms of management to what we studied when we're doing bronchial asthma. Okay. So basically we say bronchitis, as the name suggests, itis means you've got some inflammation going on there. So when you take the bronchus, remember when we're doing asthma, I tried to take you through the layers that you have an inner mucosa and then a middle muscular layer and then an outer fibrous tissue layer. So this time around, the focus is in the inside, okay, the mucosa. That's where our focus is going to be, the inner aspect. When you breathe in, the part where the air is supposed to travel before it gets to your alveoli, that's what we are going to be looking at. So basically, in bronchitis, you've got an inflammation of the inner aspect of the bronchus. This inflammation may either be acute or chronic, okay? Once we go on, we would see the definition for acute or chronic, but as we all know, chronic means that it has to be there for a certain period of time, okay? So with chronic bronchitis, you realize that this person develops it and then the disease stays for a certain period of time, okay? With the acute, we'll be talking about the acute first. So the commonest cause of the acute bronchitis is the cause that would usually be associated with our usual upper respiratory tract infection. So in acute, you realize that the person has got some sort of cough and cold, which would usually say, okay, there's an upper respiratory tract infection. And then with time, the microorganisms start migrating downwards, okay? So from the upper airway, all coming down from your larynx to your trachea, they start moving downwards to the bronchus. And once the bronchus becomes involved in inflammation, then we say that your patient has developed bronchitis. So the common causes is our usual viral, causes, what we tend to see when we are dealing with common cold and all that. So influenza virus and coronavirus and all that. So I created this slide even before the coronavirus outbreak. Okay, so what I do is I update it with time. So this coronavirus was even there, like it's been there for years. So influenza virus, coronavirus, they tend to cause inflammation of inner lining of the bronchus. Okay. Usually once you develop this viral infection, what happens is with time, because the inner lining of the mucosa of the bronchus, which is the mucosa, has become inflamed, it gives way for other bacteria to come in there and make the infection worse, okay, what we call a secondary bacterial infection. And that's why most of the time when we are managing cases of cold, even though we know that, all right, this is viral, we tend to put our patient on some sort of antibiotics because we are trying to prevent or treat a secondary bacterial infection. A classic case is COVID. Even though we know COVID-19 is a viral infection, as part of our management, we would, once we admit you, we are going to put you on IV antibiotics like Rucefin. And even if we don't admit you, we are going to put you on oral antibiotics like azithromycin. Okay, so this is an antibiotic, but then we are using it in a viral condition because we want to prevent or we want to treat any form of secondary bacterial infection. So acute bronchitis, usually the common culprit will be your viral microorganisms, and then later you're going to have a superimposed or a secondary bacterial infection. The presentation is like a combination of you having an upper respiratory tract infection and asthma. Okay, so whenever you have a patient who is coming to you at the OPD and the patient has a fever, the patient is coughing, patient has some sort of running nose, and at the same time, patient tells you, I can't breathe, my chest feels tight. You realize there's some sort of wheezing there. Okay, whenever you see wheeze or you hear some form of wheeze, your mind goes to asthma. But you should know that history is always very, very important. If you have a patient who is like 18 years old, who is coming to you with a presentation like this with fever, cough, and then there's a wheeze, and then you ask the patient says, no, I'm not asthmatic. Then you go on and ask, but do you have any family history of asthma? Patient goes like, no, I don't have any family history of asthma. Then that should actually ring a bell that, okay, this patient has a wheeze, but patient doesn't have any history of asthma, no family history of asthma. So most likely I should be looking at another diagnosis. Okay. It doesn't mean that you can't have an elderly person who starts developing asthma symptoms all of a sudden. You remember when we're doing asthma, we said we have intrinsic and extrinsic. And we said that with the extrinsic is the usual one that we tend to see from childhood and all that. That one is actually connected to a family history. And then intrinsic is more of an adult onset asthma. Okay, but in this case, the patient is 18. You expect that it's just past adolescence. If it was asthma, the patient should have a previous history or some sort of family history. Okay, but there's none. My patient is coughing with a fever, there's tightness and there's a wheeze. That should also draw your attention to the fact that this could actually be some sort of bronchitis, an inflammation over there. Once you're picking up a wheeze, then the bronchus is involved. So this could be a bronchitis. Okay. So clinical presentation, your symptoms would usually be more of a combination of upper respiratory tract infection. So you have the cough, can have a cold, the cough will come with some sputum, and asthmatic symptoms where you have tightness in the chest, you have wheezing, and then you have shortness of breath. Okay. In severe cases, you realize that the patient has got some crepitations there in the lung because of the infection. So how would you manage your acute bronchitis? You would usually need to investigate the patient first, okay? But I always say that once you have cases that patients present with some clear symptoms, diagnosis most of the time is clinical. Your other investigations you do would help you support the diagnosis that you've made. So your history is very, very important because your FBC, your sputum for microscopy, sputum for AFBs and all that, they are not specific for bronchitis. We do it for almost every respiratory tract infection. Okay, so it won't specifically tell you that there's a bronchitis, but your history and the symptoms the patient is coming with would give you an idea that, all right, okay, you're dealing with a bronchitis. Okay, so if you specifically want an examination that would pick up the bronchitis, you put this the same way you have an endoscope. They have a bronchoscope where more of a camera, they put it into your airway, they move it down, and then they can take pictures of your bronchus, and we can see an inflammation in your bronchus. And then that is a specific diagnosis where we say that on bronchoscopy, we realize you had inflammation in your lung. So yes, you have bronchitis. But most of the time, we don't do bronchoscopy for patients who have acute bronchitis. We'll do our usual FBC. We'll try and pick the sputum. We'll see if there's any microorganism in there. We'll rule out other things like TB and all that. And then we'll do a chest x-ray, all to support so that we know what we are dealing with, okay? Because once the patient is coughing, there's a fever and all that, you also want to rule out a pneumonia. And that's why your chest x-ray is very, very important, okay? So your chest x-ray comes and there's no consolidation whatsoever, but your patient is coughing and then there's a wheeze, then you know that the lung parenchyma itself is not involved, so there's no pneumonia. However, the wheeze is drawing your attention to the fact that the bronchus is involved. Patient is not asthmatic, so this is likely to be what? An acute bronchitis. Okay. Are we okay?
Yes, though.
Yes, sir, we are okay.
All right, okay, okay. So your management here, your focus is more on relieving the patient's symptoms, okay? So you are relieving the patient's symptoms and you are going to aim at preventing secondary bacterial infection. You realize that most of the viral infections, viral upper respiratory tract infections, will usually not put you on any antiviral medications, but with time, it sort of resolves. So we say the viral infections are self-limiting. So with time, it would go away. So we won't put you on any antivirals, okay? But then we would end up giving them some antibiotic. The antibiotic, as I said, is not supposed to treat the viral infection because the viral infection will go away by itself with time. However, you could have a secondary bacterial infection or a superimposed bacterial infection, which will delay patients' recovery, make temperature worse, okay? And further on, it can lead to sepsis and all that. Once you have a bacterial infection, which is not going away, it gets into the bloodstream and then you have sepsis. So the condition might have started from a viral source, but your failure to prevent a secondary bacterial infection will lead to sepsis and shock, which can kill your patient. So what we do is we will put our patients on antibiotics as well, okay? So from the management, you can see we are giving an antipyretic. The commonest one is paracetamol. Antipyretic means you want to control the temperature. And then we are giving our antitussive agents. Antitussives are cough syrup. So antitussives can either be suppressants or expectorants. You always have to take a good history. Are you coughing? Yes, I'm coughing. When you cough, do you bring out any sputum? Yes, I do bring out sputum. What's the color of the sputum? All to point you to a certain direction. Because if a patient tells you I'm coughing and the sputum is a little bit bloody, then it's pushing you to a direction of TB, maybe a direction of a lung cancer, maybe some sort of pulmonary embolism and all that, because you usually see blood in there, okay? So it points you to a certain direction. However, if your patient says, oh, yeah, Lorena, your internet is not so stable. Lorena, do you have a question, please? All right. Do you have a question, please, Lorena?
Sir, no, it was a mistake.
All right. Okay, great. Okay, that's all right.
No, sir, I'm okay.
Okay, okay. So, yes, so sometimes, however, you can ask your patient, are you coughing? The patient says, yes, I'm coughing, but then I don't have any phlegm coming. This patient doesn't need an expectorant, okay? An expectorant won't help the patient in any way. The patient is coughing but no phlegm. So you rather want to suppress the cough. So you would put the patient on a cough suppressant. Examples of cough suppressants are cough syrups that contain codeine, dextromethorphan, and all those things. They basically suppress cough. However, if your patient has sputum, then you want to help get the sputum out, because they'll tell you the cough, phlegm comes out, but sometimes it's like the phlegm is unable to come. So you don't want to give an expectorant, and cough that are expectorant to contain carbocysteine. So you want to put your patient on that. And then antibiotics come in. And of course, once the patient can't breathe, you always have to check your SpO2. And it's good to always put your patient on oxygen, especially if your SpO2 is less than 94%. The antibiotics, I always say that with respiratory tract infections, 2 main antibiotics. So if you don't remember anything at all, just know that respiratory tract infections, the common causes usually are gram-positives and the atypical organisms. Sometimes gram-negative organisms like Klebsiella can cause a pneumonia. Okay, sometimes, but of course, that's the reason why before you study your antibiotic, you've taken sample for culture. Okay, if there's phlegm, you just take sputum for culture. If there's no phlegm at all, what you can do is you can take blood for culture and sensitivity. Okay. Sometimes they can swab, try and do a bronchoscopy and then a swab. So they go down, check, and then they would swab and then they take it for culture and sensitivity. Okay. Most of the time you'd have gram-positive and anaerobes. And we know that gram-positives, the best medication to give is your penicillins. So your amoxicillin and all that. Okay, and that's why we are giving amoxiclav. Amoxiclav is a combination of amoxicillin and clavulanic acid. Okay, the clavulanic acid there is supposed to help reduce the incidence of what's resistance, because penicillins have a structure, and as part of the structure, they have something we call a beta-lactam ring. So I'm sure pharmacology, Dr. Maria will teach you. So the beta-lactam ring, usually you've got, your body produces certain things. I mean, the microorganism produces certain things called beta-lactamase. So once the microorganism is able to make a beta-lactamase, the beta-lactamase would break down the beta-lactam ring of your penicillin. Hence, when you give your usual penicillin, it won't work on the microorganism, because the microorganism has developed a certain substance to destroy the medication. Okay, so when you give your clavulanic acid, the beta-lactamase, or the enzyme being produced by the bacteria, is unable to destroy your antibiotic, and hence your antibiotic is able to work. Okay, and that's why for me, if I'll give amoxicillin, I'd rather prefer to give amoxicillin and clavulanic acid. So amoxiclav, augmentin, clavulin, all of that contains clavulanic acid. Okay. And then your azithromycin, we usually give it for your atypicals. Azithromycin belongs to a group of antibiotics called macrolides. Okay. So the friend of azithromycin is erythromycin, and there's also clarithromycin. They are macrolides, and we use them to treat atypical infections like mycoplasma, chlamydia, urea plasma. Those are atypical bacteria. So we use azithromycin in treating that. All right. So that's it for acute bronchitis. So it's kind of straightforward. Whenever you hear acute bronchitis, you are thinking of certain acute stage, you are thinking about viral infection and then a superimposed bacterial infection. Because usually it starts as a viral infection, the temperatures don't rise so high. But if later the temperatures start going up, then it means that superimposed bacterial infection is beginning to take place. Your symptoms will be more of a combination of upper respiratory tract symptoms and asthmatic symptoms. As part of your investigations, you need to listen to the patient's chest, and what you hear, because it's the bronchus that is inflamed, you hear sound like asthma. So you hear rhonchi in there. Worst case scenario, the infection spreads, and then you can hear crepitations when you listen to the base of the lung. Okay. Remember in pneumonia, we said when you listen, you can hear crepitations. And as part of your management, you're going to give your antibiotics, you're going to give you temperature control medication, cough syrup, and oxygen. Okay. So chronic bronchitis, for you to say a patient has chronic bronchitis, the patient should have been coughing for about 3 months, continuous. Okay. And then maybe one way or the other, it resolves. And then the next year, the patient starts coughing again continuously for 3 months. So you need to get the symptoms in 2 subsequent years or 2 continuing years for you to be able to go ahead and say, all right, patient has a chronic bronchitis. Okay, so it is defined as the presence of chronic productive cough for 3 months, okay, during each of the 2 consecutive years. And usually the commonest cause tends to be inhalation of tobacco smoke, industrial dust, chemical irritants, all those things. That's like the commonest cause. And usually it would occur after 40 years. So you've got a patient coming to you who has some form of cough. Sometimes when they have acute exacerbations, they find it difficult to breathe and all that. You take a history, a smoking history, you realize they've been smoking for a very long time, or they've been working in these industries where they are exposed to chemical irritants and all. Then you can boldly go ahead and say chronic bronchitis. Okay. I'm sure we've all heard of chronic obstructive pulmonary disease, or COPD. COPD is like an umbrella term, and under that COPD, you have chronic bronchitis and emphysema. Okay, sometimes they tend to add the adult onset asthma to it, so it becomes adult onset asthma, chronic bronchitis, and emphysema. So once you hear COPD, that's what we are talking about. So if someone asks you, "Oh, have you studied COPD?" We have, because we are going to talk about chronic bronchitis and then emphysema. So chronic bronchitis is one aspect of COPD, right? So the symptoms include shortness of breath, wheeze, always, because the bronchos is involved. Patients would have fever. They tend to have a productive cough, okay, for a very long time. And then they live with a condition, so it becomes chronic. But at a certain point, they develop what we call acute exacerbations, okay? So they get to a certain point where they realize that they are unable to breathe, they are breathing fast, their oxygenation level is dropping. Because if you've got this and then you stress yourself, okay, then you start having problems. Ideally, when you've got something like this, your body tries to compensate. So even though you are coughing most of the time and all that, your body tries to put you in a constant balance or some sort of homeostasis, whereby oxygen diffusion into the blood and carbon dioxide diffusion out of the blood is possible. Okay, but what happens is once you develop a decompensation, then there's a problem. Okay. Yeah, Esther, you got a question?
Yes, Doc. And
Yeah.
please, with a COPD, is it that the 2 conditions make up that diagnosis? Is that what you are saying?
Yes. So the COPD,
Right.
Yeah, so the COPD is a term, and once you open COPD, it will tell you that there's chronic bronchitis and there's emphysema. You don't need to get all the 2 for us to say you have COPD. So the COPD is more of an umbrella term.
Oh,
you realize that their presentations are a little bit similar. You'd see it. Okay. So the COPD is chronic obstructive pulmonary disease. So it's not just one condition. So any chronic condition that you basically have an obstruction to airflow would fall under chronic obstructive pulmonary disease. The main thing there's an obstruction to airflow. Obstruction to airflow the tissues, and carbon dioxide is also not coming out of the tissues. So it means in the end, you're going to have a lot of carbon dioxide in your blood because it's unable to diffuse and come so that you'll be able to exhale.
Oh, okay.
You get it?
Oh.
So that's it.
Thank you, Doc. Thank you.
You're welcome. You're welcome.
Hello, Doc.
So what? Yes.
I have a question.
Yes.
The definition of the chronic bronchitis, it said defined
Uh-huh.
as the presence of chronic productive cough. Does it mean that if the
Yeah.
cough is dry, it doesn't fall under chronic bronchitis?
Yeah. So most of the time, the cough in chronic bronchitis will be wet. Okay, it comes with a sputum.
Okay.
So if you are dealing with a chronic bronchitis, you are supposed to get that.
Okay.
Okay. Even if it starts as a dry cough, eventually it starts getting wet. That's the classic thing it comes with. So if you're having a dry cough for that long, then we should be looking at something else. Maybe we are dealing with an allergy, because allergies also tend to be chronic.
Okay.
Okay.
Okay. All right. Thank you very much.
All right. You're welcome. Yeah, Edmond. Uh-huh. Edmond, I can't really hear you. I don't know if you can type the question so that we address it. Yes, I would be grateful if you're able to type. So we'll be waiting for the typed message and then we'll take it from there. All right, so what's happening in this case is I said that there's an obstruction to airflow, right? So once you go an inflammation in the airway, you remember when we're talking about asthma, we said there's inflammation and then there's mucus plug and all that. So air goes in, and once the air goes into the airway, there's some sort of obstruction to the airflow. We expect that air would flow through, goes through the trachea, goes through the main bronchus, goes through the other aspects of the bronchus, gets into your bronchioles, and eventually gets to the alveoli. And at the point where it gets to the alveoli, you have gaseous exchange. You have oxygen diffusing into the blood and carbon dioxide coming out of the blood. And once this happens, the carbon dioxide will go through the same process and then exits from the trachea, and then you expire. Okay, so that's what is supposed to happen. But when you have any obstruction to this, then what is going to happen is air comes through the trachea, all right, but when it gets to the point where we expect it to move through the bronchus, then there's an issue. Okay, so it's unable to move all the way down to your alveoli, and once that happens, then it means gaseous exchange is going to be a problem. Okay, the slightest carbon dioxide, which is also able to come out, would also face an obstruction, and expiration or bringing it out becomes what's difficult. So in the end, you see a patient who is trying very hard to force carbon dioxide in. So the patient is breathing in, but when it comes to expiration, there's some sort of increased expiratory effort to push the carbon dioxide out, because we don't want to keep carbon dioxide in our system. Okay, so what is going to happen is, because you have carbon dioxide trapped there, this carbon dioxide that is trapped in the distal parts of the airway, and then the rest of the carbon dioxide that is not able to come out will stay in the blood, and then you develop what we call cyanosis, meaning that you see a patient who's in people who have pink or white lips, you realize that it looks purple, and then those who have darker lips, you realize it's even more darker than the usual. Okay, and then they can sometimes develop what we call clubbing. Clubbing is a condition whereby you have a systemic disease, or you tend to have a condition in another part of your body, but then when you look at the fingers, you realize the fingers are looking like a club shape. Okay, so maybe when we meet in class, I'll show you pictures of clubbing and then the stages of clubbing. Then they develop a wheeze as well, because as I said, we are dealing with the bronchus. What is going to happen here is, because the air is trapped in the airway, right? You've got a lot of air just trapped in the airway. It's not getting into the blood and all that. So the lung sort of what inflates, okay? And once the lung inflates and there's a lot of air in the airway, when you percuss, it's going to be what? Hyperresonant. You remember when we're talking about percussion in pneumonia, we said because there's a consolidation, means the air has gone out. When you percuss, it's going to sound what? Dull. If there's the air has gone out and then there's a complication of the pneumonia and you have water in the pleural space, we say what's pleural effusion. And pleural effusion, when you percuss, is going to sound stony dull. And we said another thing about when there's excess air in the pleural space, which we call what's a pneumothorax. When you percuss, it's going to be a hyper-resonance. Ideally, when you percuss any normal lung, it's supposed to be resonant, okay? But when you percuss a chest that has a lot of air in the pleural space, which you call a pneumothorax, then it's going to be a hyper-resonance. The same way when you have a lot of air trapped in the airway, because this time the bronchus is inflamed, air is not able to move, so there's air trapped in the airway, air is not really coming, carbon dioxide is not coming out, oxygen is not really going in, so it's all stuck in the airway. When you percuss, what is going to happen is it's going to be hyper-resonance, okay? And ideally, when you percuss the chest and you percuss over the area of the heart, because the heart is a solid structure, solid like, let's say, when the lung becomes pneumonic or the lung becomes consolidated, when you percuss, remember we said it sounds dull. The same way, the heart is a solid structure. When you percuss over the heart, we expect that it will be what? Dull. But once you develop a chronic bronchitis, you are going to lose that dullness on the surface of the heart because you have a lot of air trapped in circulation. So when you percuss, there will be, the heart area would also sound resonant. So we say there's loss of cardiac dullness, okay? So those are the things you're going to see on examination. And I think the call will drop soon. So what we'll do is we'll take Edmond's question and then I'll drop the link and then we'll connect again, okay? I can't see the question, so if someone can look for it for me and then read it out for me, I'll be grateful.
Okay, Doc. So the question reads, please, doctor, do we have an acute obstructive pulmonary disease, into brackets AOPD, and how would that be classified, just like COPD suggests?
All right, okay. No, so in medical terms, I'm here to come across acute obstructive pulmonary disease. Okay, what I'm conversant with is a chronic obstructive pulmonary disease. Once you are talking about acute obstructive, even if there was anything like that, then we'll be talking about acute bronchial asthma or something of that sort. Maybe you have like a bronchial asthma where you have an acute exacerbation. Okay, then we'd say, all right, okay, maybe this is an obstruction of the airway. And in this case, you have an acute exacerbation, just like what we tend to see in what? Asthma, okay? Or probably you have a patient who is drowning and the patient has got a lot of air stuck in the water stuck in the airway. So this is an acute situation, not a chronic situation. So then you can say, all right, okay, so the patient has some form of acute obstructive pulmonary disease. So when you look at it, you are going to have a lot of causes for that. All right, but I'm yet to see a term as such. I'll also take a look and see, but I mean, in my reading and all that and practice, I haven't seen acute obstructive pulmonary disease as a major diagnosis, which has subclassifications. But I know that with that idea, there could be something like that. When you are talking about drowning, you're talking about asthma, these are all forms of an acute obstructive pulmonary condition. Okay. Are we okay?
Yeah, thank you.
All right, okay, sure. So we'll drop the link and then we'll all join again and then we'll continue. Thank you.
Kind of.
Okay.